Welcome back. And if you're just joining us, welcome to Mobilize Women. I'm Samantha Schwartz, VP of Customer Experience at Elevate Network. And thanks so much to my co-host, Tammy Williams, for her brilliant emceeing for the first half of the day this morning. Every year at Mobilize Women, I'm always wowed by the authenticity, generosity, and curiosity from our speakers and from everyone in the audience. So far, what stands out to me from the day is the focus on honoring what makes us human. I hope that all of you will walk away from today with your own action tips for making this world one that brings more voices to the table. Next up, we are going to talk about women's health uprising, rights, access, abortion. Now, without further ado, please welcome to the stage Dr. Cindy Tsai, Integrative Medicine Physician at Yes and More, Dr. Diana Contreras, Chief Healthcare and Health Strategy Officer, Planned Parenthood Federation of America, Janine Versi, co-founder and CEO at Electra Health, and Dr. Sabrina Das, obstetrician gynecologist for Médecins Sans Frontières and Imperial College Healthcare Trust MSF UK board trustee.
I think you muted, Cindy.
Hi, everyone. Thank you so much for joining our Women's Health panel today. I'm Dr. Cindy Tsai, and I'm a wellness consultant, TEDx speaker, and double board certified physician in internal medicine and integrative medicine, focused on women's health, stress management, and hormone balance. And I'm really honored to be the moderator of this amazing panel discussion today. Before we dive in, I want to invite each of our panelists to share a quick 1-minute intro about themselves, and then we'll get into it. So let's start with Dr. Diana.
Hi, I'm Diana Contreras. I'm an OBGYN by training and a women's cancer specialist. I joined Planned Parenthood 2 years ago when we were beginning to see what was happening in Texas and the tremendous effect that was happening to women's reproductive freedoms. So I'll leave it there, and I'm really excited about being on this panel. I think there's a lot of really important things that we need to talk about.
Thank you. And how about Janine?
Hi, everybody. My name is Janine Versi. I'm the co-founder and CEO of Electra Health. I'm honored to be on this panel with so many luminaries. I'm not in medicine myself, but I do run a virtual women's health organization called Electra. And for the past 5 years, we have been building the space really focused on perimenopause, menopause, and helping women navigate those decades of midlife health into the Medicare years. And we do that with virtual care, but also access to experts like menopause doulas to help with navigation and meeting women where they are to educate them with evidence-based information. Thank you.
Thank you. And how about Dr. Sabrina?
Hi, everybody. My name's Sabrina. I'm an obstetrician and gynecologist. I've got a London-based practice. My specialist interest is in high-risk pregnancy, quality improvement, and also complex surgical abortion. In addition to this, I bring to the table the UK voice from another high-income country across the pond from you guys, and also representing Médecins Sans Frontières as a board trustee, as well as an OBGYN that's worked in Yemen, South Africa, and Guatemala.
Thank you for that. So let's first set the stage and see where we are in terms of healthcare access for women in 2024. And I would love to have everyone comment on the most significant barriers to healthcare access for women today, either locally and or globally. So let's start with Diana.
Yeah, so I guess the thing, if I was to say that what keeps me up at night related to access for women's healthcare has to do with what's going on in reproductive deserts that are happening in this country, both on the maternity side, on hospital side, and on the contraceptive deserts that exist. And I think that's probably the thing that is most disturbing. Also exciting that there are now other modalities, but I do think that for many people in this country, the reality is that they can't access care because it's not there. So I think it's really important people realize what's happening in this space.
Yeah, absolutely. I think awareness is really important. So thank you for that. And how about some of our other panelists?
I can speak to the kind of low income setting kind of experience. In humanitarian medicine, we talk about, in terms of access to care, the three delays. And this is a really big concept in terms of how you think about maternal mortality and the reasons why women die from complications in childbirth. And the first delay is the delay in even in within the individual and then the woman and her family even thinking about accessing care. And that brings in things about trust of the hospital, trust the relationship between local community and healthcare providers or formal healthcare providers, and also education. So education is really, really important. And the second delay is the time taken to actually get to the healthcare facility. I had a woman die when I was in Yemen because she lived 2 hours from the nearest hospital. In the middle of the night, she had to, the barriers was to, she had to call her uncle to get a car. And then, you know, when she was in second stage of labor, she had to get in this car and drive the 2 hours, et cetera, et cetera. And when she went to the first hospital, they wouldn't actually care for her. And here is the third delay. It's a delay that actually happens in the hospital, because even once you get to a healthcare facility, there are delays in terms of how women can access care because of structural issues. In this particular hospital, they didn't want to treat her because they thought that she was too unstable to treat. And they didn't want to have another death on their books because of the stigma with death. So then she came to my hospital. And by the time she got to me, she had been dead in the car for 10 minutes. And it was absolutely heartbreaking. And I hate to tell this story because I have other more uplifting stories later on in the panel. But when you talk about access to care, it's so much more than just the legal framework, which is really important. It's also the affordability of care, the acceptability of the care, and of course, as Diana has pointed out, the availability of the care.
Yeah, that's definitely, that story, I think, is really, really hits for many of us. Janine, anything come to mind that you wanted to share?
I think, I would underscore what has just been shared. And maybe what comes to mind for me is less of my current role, although I do certainly have thoughts on the obstacles to care that we face as we age. But as a humanities student and someone that grew up around the world is and ties to what the opening speaker was saying is, I think the rollback of democracy locally, nationally, globally is bad for women and is bad for women's health. And there are things that we can do about that. And it does require, participation and civic engagement. And I think sometimes it feels very hard with atrocities, with war. But I think that we all have a responsibility to buckle in and engage and fight back. And so I think that's a sort of meta comment coming from someone who studied history for a long time before I moved more specifically into women's health. And then as we think about, women's health as we age, I think a lot about the fact that women are living longer in the United States, but with poorer health outcomes. And how and where do we intervene? I think what Dr. Das said about education is really important. How do we help people equip themselves with information to not live out their last years in settings that they wouldn't want to choose for themselves, perhaps infirmed physically, without the, sort of support that you would want. And so I think that preventative care, and it sounds so abstract maybe, but we have to make it much more concrete in the 40s and 50s. How do you want to live if you are going to be in your 80s and 90s? And so that's, another sort of more concrete way in which I think about barriers in women's health over time.
Yeah, and we also want to say that it's not all bad, right? So maybe we can share some examples of countries or industries that are getting it right. Does anything come to mind? And open to all to share.
So I'd like to share, as Planned Parenthood has been really involved in several things, including the access of birth control going over the counter, which I think is a huge issue if we think about how the impact of contraception has been for women overall. And the idea that this is has gone over the counter so that people can access it in so much of an easier way, I think is really important. A second area that I think is critically important that we've been seeing the impact of is emergency contraception has gone over the counter and is going at a lower price. So it's price availability and access, two really, really important things that I think are really critically important, and how much they have changed people's ability to access. And finally, I want to say, as somebody who's spent probably my entire professional career in women's health, what we're seeing today and the interest in women's health, the funding, is unprecedented in this country and really super exciting. We have to be very conscious of the other side of what's happening, but I do think at the same time we have to keep the perspective that we're having even conversations about menopause, which we were not having years ago, right? And so and this idea of how you want to live your life are also concepts we weren't having in the past. So I do think it's very optimistic. I think it's an opportunity for us to also be grounded in what's being eroded, and we need to make sure that we're keeping our eye on the ball on both sides.
I can give some examples as well. I completely agree with you, Diana, that if there's one good thing that's come out of Dobbs, it's just made abortion a normal thing that you can talk about, at the dinner table, at a party. It is a normal thing that me, as a mother of two daughters, I can speak to them about it, and they're aware of it. All over the world, I have to say. And Mexico must just be so proud of legalizing abortion in the wake of Dobbs, and has done so much, which I think is amazing, because I'm not American, but I know that Mexico has a very complicated relationship with the US, and yet still Mary Stopes and Fundación Mary Stopes have clinics, and they've set up specific clinics to provide abortion with the thinking that they're going to have American clients coming over to Mexico to abortion. Las Libres, which is another very experienced and active group in Mexico in supporting Mexican women access abortion when it was legal, is now doing the same in supporting women coming from America, or even with abortion doulas and peer support through self-managed abortion, helping American women in that way. I just think that's amazing, how Dobbs has actually inspired women in this way. I've got something to signpost everybody here. The Commonwealth Fund, who I'm very well acquainted with, has recently published a review into maternal mortality and comparing high-income countries and what kinds of healthcare policies happen there. And I'm just so proud that the things that they've highlighted we do in the UK, we do in the country in which I work, which is focusing on midwifery-led models of care for low-risk women, offering an option of place of birth in freestanding midwifery-led centers or home birth for suitable women. And we know, as obstetricians, we know that the evidence shows that in selected group of women that have recourse to transfer into hospital if needed with qualified midwives, this is a very, very safe way to give birth, and actually reduces the number of unnecessary cesarean sections, assisted vaginal birth, episiotomy, etc. I'll put my hand up and say my second baby was born at home, and I'm just so proud that the UK is able to offer this to women. So, something to take away as a model of maternity care.
Thank you so much for sharing. And I wanted to get into some specific questions. So first, for Diana, as the Chief Health Strategy Officer at Planned Parenthood, I'd love to hear more about how you go about developing strategies to address disparities in health, such as with abortion bans disproportionately impacting communities of color and Black women. And if you can share any successful initiatives or ideas on what could be done to better support these communities.
I think a big part of it has to do with making sure that the correct message is out in the public. I think frequently what happens is patients are confused as to what state they can get care in, where they can get care, how they can get care. There are a number of organizations, including our organization, about helping people to get to care, both on the abortion side and on the contraceptive side and all of women's health. That our commitment is we will provide abortions where we can, and we will provide regular care for women everywhere that we are. And we will help people to access the care. And I think one of the things that concerns me the most is the confusion that's gone on and the chilling effect that's gone on. So I think sometimes people don't realize what has happened in our space. Physicians and providers are scared. And when people are scared, they leave a community and go to where they can provide the care that they feel safe providing. And so the impact is huge to the entire community, because when you have OBGYNs and family practice doctors and all kinds of providers leave a community, they actually leave the community because they can't provide the care that they've been trained to and are committed to doing. And they leave all the other care without being able to be attended to, not because they're bad people, but because they want to be able to give the right kind of care. And so what happens is we work very hard to make sure that the message is clear as to what you can do and what state, what age. Gestational ages are so confusing in this country. And so we work very hard to make it clear for people. And for those who can't get the right kind of care in their community, we help to get out of their community and get to places where they can. So if that answers your question, I could go on forever because there is so much. But I think having the right message is critical to all this and how we help people to get the care that they need and want.
Definitely. Thank you for that. And Janine, we see that Electra Health focuses on supporting women through menopause and beyond. And what are some of the key challenges that women face surrounding the menopause time and transition? And maybe tell us a bit about how Electra Health addresses these challenges through evidence-based care and support.
Sure, I'd be happy to. Just to speak briefly on the prior question around, things that were positive on, I want to add a couple things. One is that I think, credit to this panel. In this time of crisis, and in many times of crisis, we have incredible physician and clinical leaders stepping up, doing the work with their patients and going beyond to educate, to advocate, and put themselves oftentimes, at risk. And I just want to say how inspiring that has been and to thank you for that work, because it doesn't go unnoticed. The second thing, very quickly, is the UK, where I happen to be born, is a further ahead, I would say, in the menopause space relative to the US. And so, small example, and Dr. Doss, you know better than I, but making vaginal estrogen available over the counter, for instance, is a very sensible thing to do. It is inexpensive. It can save women from recurrent UTIs that, as they get older, can land them in the hospital, can kill them. So, there's just a sensibility there that I think we appreciate and ought to look to more often. And then briefly on Electra, many challenges in this topic of women's health as we age. And I think it's important to say we use the term women, but not all women go through menopause. People who don't identify as women may be going through menopause. And also, this is not just for women. We all need to be aware of this, just like puberty. This is a thing that happens that is not optional. And so we all ought to be educated and aware. But we've, as a society, I think, internalized the concept of women's suffering is acceptable, especially if it doesn't relate to family building or becoming a mother. And so, in the US, where I think we often struggle to hold two concurrent thoughts in our head at once, like Dr. Contreras said, like we have to be able to honor the wins and what's positive, but while keeping an eye on the problems. And I think that sometimes in our space, we talk a lot about maternal health at the exclusion of what are the risks that women face in those decades that come right afterwards, when the risk of chronic conditions accelerates significantly and the menopause transition is tied to that. We know from the research, and women deserve to have an educated conversation on this topic. So I think education, access to care, there are very few providers who are sufficiently trained Mayo Clinic surveyed a bunch of recent trainees, OBGYN and internal medicine, and only 7% feel prepared to take care of menopausal women. So that's pretty atrocious. I could always speak more about Electra, but I'll just pause to say that our model is virtual. We combine both the education and support from non-clinicians, because that's how we access more people at scale and meet them where they are, and then connect them to clinical care, whether through our platform and our own providers who are very highly trained, or through partners that we work with and we trust in terms of in-person care. So happy to speak more about that, but I'll pass the mic back.
Thank you for sharing. And I think what we're really seeing is the importance of education, of awareness, and really getting the right message out there. So, and Sabrina, I know that you're involved with the global community and would love to hear from you in terms of some of the issues, situations that we should be aware of, and any recent innovations in women's health, public health that have really great potential to help us move the needle.
In terms of your first question about issues to be aware of, I mean, I think the thing that springs to mind, I'm sure for everybody here, as the most pressing problem is how I don't even think, 10 years ago when I was a medical student, 20 years ago, I would have thought that war was going to be a problem, or that the threat of a world war might be a problem. But I think we all feel increasingly insecure in in our situation, our global peace situation, with what's happening in Ukraine, more recently in Gaza, and lots of unspoken conflicts, which our audience may or may not even be aware about, in Sudan. When I was working in Yemen, that was in 2021. The country had been embroiled in civil war for 6 years by then, and it's still ongoing. It's not been resolved. If anything, they're escalating because of Gaza. So, in terms of something to be aware, I think we see a lot of images of casualties of war. But when I was in Yemen, I really saw that chronic effect of war onto women, and women bear the brunt of war when it's lasting for years and years, which Ukraine now has gone into now, because it then impacts the roads, it then impacts the schools, it then impacts the sanitation, and really, really basic things like, cholera or like safe water then becomes really, really important. So I think having that widened perspective on what it means to be a healthy person, and the factors that need to be there in order to have health in women, in children, in communities. It's more than just hospitals and clinics. It's schools, it's education, just like Janine was talking about. It's financial autonomy. So it's access to good jobs. One of the things I'm most proud of with MSF is that it's an employer, it's a global employer, and provides loads of really, really good, high quality jobs with professional development for men and women. And in countries like Afghanistan, where these things don't exist, or in Yemen for women, it actually provides women with the financial autonomy to be in themselves, healthy, and to influence in their families in terms of their access to health. In terms of innovations, it's all about the simple stuff. And I learned so much working in low-income countries that you can take back to your personal setting. The first thing is about community engagement. I think that we do this really well in the low humanitarian setting in terms of having health promoters as part and parcel of your medical team. I don't have that in my fancy London hospital, where you have health promoters whose actual job is to go in and engage directly with the community, and to build that trust, because this is the reason why Black and brown women are suffering historical intergenerational trauma from the institutions that they've suffered by. And this is why they don't come. This is why they delay their treatment, whatever country you're from, is the US, the UK, or in any country. They delay treatment because they do not trust. And the way you build trust is to be in the community and to have non-medical staff provide that support as well. All the innovations that we use, it's about, it's just simple stuff. It's like self-managed abortions, using misoprostol putting the power back into the community and into the women themselves, putting the misoprostol tablets into the hand of the woman so that when she's giving birth and being assisted by a traditional birth attendant, she can just swallow those tablets and she can have no fear that, you know, that that's going to harm her. And she knows that that is going to actually reduce her chance of having a life-threatening hemorrhage. So yeah, lots and lots of really, really good stuff happening. And it's all simple things that we can do that's within our power.
Yeah, thank you.
Can I play off of something that Dr. Das mentioned? And I think it's really critically important that when people realize the downstream effects that happen and the collateral effects that happen with things. So I'll give you an example. We talk about abortion bans in certain states. When you have abortion bans in states, providers leave the state, as I tried to explain before, because they can't do their job, especially in states where you're talking about OBGYNs, maternity units close. When maternity units close, hospitals close. And so now you're a 50-year-old guy who's having a heart attack. There's no hospital because we started off with a ban for abortion and ended up losing the entire community's healthcare system. And I think people sometimes don't realize what can happen. And I think that's what you were referring to, Dr. Dawes. It's critically important that the downstream effects that go on are really part of this. I think it speaks to menopause and what Janine is talking about. The workforce is over 51% women. If we don't address what's going on with menopause, who's going to keep the workforce going? It's about the downstream effects, and that women and the gender expansive community are really important players. And we need to start standing up to say we count, and what you're doing to our healthcare has huge ramifications on the entire system and how we do business out there, as well as not just the healthcare system. It has a huge ripple effect, and I sometimes don't think that's appreciated. So I really appreciate what both of you have been bringing forward.
Thank you for sharing. And definitely we appreciate hearing the global perspective and understanding a little bit more about what's going on with current events and all of that. And I think a big part of this is really helping women see the importance of self-advocacy and really having the right people and support. So, you know, in terms of community, healthcare, and all of that. And I think we see that when there's necessity, that oftentimes drives innovation, right? But we have to also know what the current situation is. I appreciate, you know, talking about having the bigger picture of the downstream effects too, right? So we can identify the opportunities and really best address it to move forward. So I wanted to circle back to Janine. With your background in both tech and healthcare, I'd love to hear a bit about how you see technology transforming women's health, particularly in areas like menopause and maybe some innovations on the horizon that could really impact women's health outcomes.
Sure. I think the obvious one is the advent of virtual care. I think people, depending on which circles you run in, are sort of like, oh, telemedicine, like that's tired, that's come and gone in the COVID era. But I actually think that we're really at just the tip of the iceberg, because the access issues are getting worse and not better. And so it's not to say that we ought to replace in-person care. It is to say that we have to be much more intelligent about which patients can be seen under what settings and by whom, frankly. Speaking of health promoters, speaking of allied healthcare professionals, as well as different types of clinicians. And so I think that's where, there's so much promise of technology to be able to leverage the right data at the right time and get people seen by the appropriate providers. But I really think that, as we think about healthcare deserts, as we think about access to care, it's really important that we continue to promote virtual care as a strong option, even when incumbents are looking at billing and they would like to roll that back, or certain stakeholders have an interest in reverting to the traditional system. I think we need all options on the table. And then I think that the other piece of it is just how do we engage people around their health and well-being? And it's really what, both Dr. Doss and Dr. Contreras have talked about, but, in the community using, people are on their phones. And I'm talking about individuals who are uninsured, who have Medicaid, may not have Wi-Fi, but they often have internet-enabled devices. And this makes the experience of healthcare so much less. Just less bureaucratic, less difficult to navigate, and bring like the simplification tools to the fore, so that we can give people some time back. I really think that when you're working all the time and copays are a significant burden, and taking time away from a job and transit, these are all ways in which using technology on your phone, even text messaging, can really help to streamline, and I think can be game changing for people.
I really appreciate that comment. And I think it's important for us to take a look at how socioeconomic factors really influence women's healthcare experiences and outcomes. And would love to hear from all our panelists and your thoughts on maybe what role that policymakers, healthcare providers, and communities can play in addressing these disparities so that we can promote equity and well-being.
So I can jump in there. I think one of the things that people have to understand is much of our healthcare system was not built on women. We were seen as little men. And until we recognize that many of the things that were developed for men do not apply for women, it's really not going to work. We know that cardiac disease presents differently for women than it does for men. And so until we accept that and start training around that and understand that, and that medications function differently in women than they do in men, we won't get to where we need to get to. So the first step, I think, is really pulling back the idea that we are little men and that we need to start working in this in a different way, and really acknowledge and push the medical system that they have to acknowledge that women have different issues than men. I don't know if any of you saw the paper from Science that came out last summer about the big issues that are going on in women that don't go on in men and do not get the funding. Things like migraines, very common in women, less common in men, really affects people's quality of life. Little to no research being done on it because it's not recognized as a man's concern. And I think that's where the menopause place has also suffered, because funding has not gone into that space. And I think until, and I'm going to go, I'm on my soapbox here, but until we change some of the funding and until we change our payment systems, we are not going to get to where we need to go. So what do we need? We need community activism. We need public policy and people who step up and say funding is important and how people get paid for what they do in women's health matters. Then we'll start seeing things start to change, like we've seen a little bit happen. But until we change those things, this will be just a flash in the pan that goes away. And we really need to step up and say this is not acceptable and push the system hard. So
I have to co-sign that. I think if there's a call to action there, it is many of the people in this community have employers or are an employer, have certainly, in the US, representative government, take a minute to call, because it matters. I mean, it really, really matters. You call your health plan and you say you want this access to care to be covered. They have to log that. Their public comment periods use that.
I think businesses, there's a huge opportunity to have your voice heard, because your employer will listen to you if you make it clear to them what you need. Because the benefit managers don't necessarily know what the employees want. And women represent a huge number of employees. They can change what goes on in their companies. So I'm with you. I agree 100%.
Yeah, so thank you for sharing those thoughts. And I definitely agree. I think it's so important to realize that a lot of times, especially how we practice medicine, the studies that were done decades ago, just even looking at the populations that were included They're
That's
oftentimes not diverse, right? And yet we are generalizing the results to use it for women, for other communities. So I 100% agree that we really need to broaden that. So Sabrina, did you have anything to add?
I suppose the only thing I have to add to that is about how currently the financial models included where I work in the UK incentivize the wrong way of working.
That's right.
So we don't incentivize preventative care. We don't incentivize public health measures. We're very reactive to whatever happens, whatever problem comes here, we react to that. We know how to financially model and fund. You have a heart attack, let's pay for your heart attack treatment. But actually, it's not very sexy and it's not very exciting to talk about, prevention. But that is actually really the key to health and long-term health. And public health is all the boring stuff. It's housing, it's schools, it's jobs, it's paid parental leave. It's recognizing that mental health is just as important as physical health. It's stuff like social prescribing, like prescribing, encouraging patients to take control of their health and going to the gym and increasing activity, physical activity, etc. They come to my consultation room and they spend 20 minutes with me. The rest of the time, 23 hours and 40 minutes of the day, they're spending in their own company. So, that's the fundamental shift in healthcare that needs to happen.
Absolutely. And being mindful of time, and this has been such a great conversation so far. And we want to make sure we have some time for Q&A, but I would just love to hear from each panelist to share maybe one or two action steps that our listeners can take to help themselves personally and help the collective move forward. So whoever wants to start, feel free.
So I'm going to suggest people have to get really informed and really demand from their politicians, from their employers, from anywhere that they can, that they get seen and heard for their issues. I am very concerned about something like EMTALA, of what's going on, the EMTALA case. I'm not sure most people understand EMTALA. EMTALA was actually developed when hospitals turned patients away from the emergency room because they couldn't pay or the color of their skin. And what I am very concerned about is that they will go back to that. When my grandfather, who was an immigrant to this country, had a heart attack, he got turned away from 3 hospitals pre-EMTALA because they could. And we can go back to that if we were to lose EMTALA. I think it is, again, the collateral damage of abortion and women's health, or it's the canary in the coal mine for what's going on in healthcare in the United States today. They will then be able to turn people away based on the color of their skin or the insurance. EMTALA says you cannot ask about payment till after you've taken care of the patient. We lose EMTALA, they will ask that first. And that becomes a huge issue for emergency room care in this country. And it is emergency room care that people are dependent on sometimes because that is the only form of care that exists in their communities. I am very concerned about what's happening to people overall and what's going to happen to women, as women tend to get the short end of the stick here always. And women need to get together and recognize that this is unacceptable, because not only will they, but their families will be affected by all of this. We are a powerful group of people if we actually linked arms together and recognize which problems we want to solve. We can solve them because we're problem solvers all the time. So I have a lot of faith in what women and the gender expansive community can do when they get riled up, and we just need to get things done.
I can go next. To my token to leave you with is all about ensuring representation, following on from Lauren's keynote, because I think this is something everybody here can do, like whatever space you work in, whether you work in business or commercial sector or a startup or in health or in policy or in government, you can demand that data using an equity lens. So every single aspect, from your HR aspect, from who you're promoting, from who you're hiring, to actually, if you work in health like me, the outcomes of your patients, ask your business analyst to provide you some kind of scorecard or whatever, but with an equity lens. So you have to collect the data before you can even act on it and before you can actually measure or do something to improve your outcomes for the most vulnerable people that we are trying to serve: Black and brown people, immigrants, people who don't speak English, women, LGBTQ colleagues and patients and clients. So yeah, that's my little tip and token, is to start thinking about equity from a data-driven point of view, because that's the only way we can actually be effective.
I think you're on mute.
Only adding that these conversations really matter. So, showing up and participating, and then telling your friends, your colleagues, your family, I had this, opportunity to listen to this panel, or I'm going to mention the word menopause. I'm going to bring it up and normalize it in another space. And that is how we, I think, move this whole space forward, whether that's, specifically around menopause or reproductive justice or abortion. It's speaking up and speaking out. And I think it's very much in the theme of linking arms with the wider community. But it does take a little bit of bravery, and perhaps in an unusual setting. And so I would encourage everyone to think about, when can you do that today or this week?
Yeah, definitely. Thank you so much for sharing all of your insights, experiences. And I know we got a lot of questions come through as we were in conversation, and we'll see if we can at least do a few. So one question from Jamie is, what are the efforts being made to remove barriers in respect to women identifying individuals within the LGBTQ plus community? And is there additional training that health practitioners complete to not disrespect and possibly re-traumatize these individuals? As you know, we want to be advocates for all communities. So feel free, anyone who would like to share.
Well, as you know, Planned Parenthood is committed to providing gender-affirming care and really open to caring for the entire community. And we try to provide care in a way that is respectful and valued in the way that people want their care to be provided. The medical community, there are some folks who go in and actually try to be trained additionally in that direction, are very sensitive to it. Has the medical community as a traditional community embraced it not to the way it needs to be? And so I do think that there is fundamental training that needs to go on in a different way. And I think one of the things that the LGBT plus community could do is really galvanize around the idea of how is it people want to be taken care of, which is different than what we're traditionally trained. And I think there is power in numbers. When I think about what happened in the HIV space in the 90s, how much people demanded things differently and how much that has changed. I think there is a huge playbook that's out there of what can happen when a group of people are very committed to making a change. It's inspirational. So I would suggest that we have to make it happen, because it's not going to happen on its own.
Would any of the other panelists like to comment on that?
Oh, no, I think that was really well answered, Diana. I mean, the only thing I would add is, I just think co-production is just co-production all the way, because, it's the same principles with any community. Don't purport to imagine what somebody else wants. Just go and ask them, as Diana has said.
Yeah, absolutely. And I see a question more specifically for Planned Parenthood, asking about how can we get the Planned Parenthood and women's health choice options into middle schools, and whether or not Planned Parenthood has safe care access details in multiple languages.
So we do have them in multiple languages, and we're looking to get even further into more languages than we're doing today. As far as sex education, or even just education about you and your body, it's a very interesting and problematic space, because these are state regulated, often unfunded, or they can be mandated and not done. It is quite amazing how few states actually want, have regulations stating about education. So Planned Parenthood is in a lot of schools in the states that we can be. We partner with the school systems where we can. I would also advocate to any parent out there who is interested in having this happen. We need help. We need help on the activist side, to get out there and make sure your local politicians know how you and other parents feel, because we can provide the information and the education. The problem is that there are states that don't allow us to do that. And if you think of how restrictive many states are in this country related to abortion bans, those are many, and there are more states that do not want education in the middle schools that we can get involved in. So we're there. We'd love to be more.
Yeah, thank you for sharing. And a question came in about thoughts on the shortage of medical doctors specifically in the US, and the need for PAs, nurse practitioners, to provide care. And I think all of us on this panel have had interactions with the healthcare system, on all levels of practitioners. So would love to hear any thoughts anyone wants to share.
I mean, we have the same problem in the UK, and there's a lot of debate at the moment of the use of physician's assistants. And I think the US have, because I used to live in the US, I have interacted with PAs, and I think they maybe their journey in utilizing PAs as physician assistants has been there for a longer time. So we could probably learn from you guys and how you've done it successfully. And also, what are your outcome measures? What are you actually trying to measure as what the success look like, so that you're not just changing something and then not knowing what's happened and what the unintended effects are. The concerns in the UK with the use of physician's assistants is, I think, with the necessity for them to be supervised by a physician as well at the same time. So I don't think it's a necessarily replacement for doctors, but I do really, really believe in the use of allied healthcare professionals. As I'd mentioned already, doctors are not the only people, and often doctors are not the best people.
Right.
There's lots of examples of how you can utilize, community health workers, nurse practitioners being one of them, and obviously my favorite people, midwives, to deliver care in an even better way that's non-interventionist. And when you talk about public health point of view, preventative medicine, often it's not doctors that are needed. It's people like dietitians, teachers, physical trainers, all these people, mental health specialists, psychologists, that are actually really needed. So I don't know much about this debate in the US, but these are my thoughts around it.
So the issue in the United States has to do with this is state regulated. And so some states have moved in a very progressive way, giving nurse practitioners and midwives and PAs a lot more ability, and pharmacists a lot more ability to do things. I think it's 29 states or 31 states where pharmacists can prescribe in this country certain provide certain prescriptions. I think there is a movement in that direction. It really is state directed. And I think one of the things that's hard to understand in this country is there are 50 different ways of providing care. And so we can't generalize, but there has been a huge movement over the last several years to be expansive. And some states have come along and have really been able to enable allied health providers to be much more involved in the healthcare system, which is what we need them to be, because there aren't going to be enough physicians to meet the needs of the future generations. So fight for your state. Whatever state you're in, make sure you're a state that can do it. And if you can't, then go make sure that that's something. If that's important to you, it's something that happens, because it's on a state by state basis.
I'm more concerned about the shortage of nurses, to be honest, because I feel like the nursing role is something that you can't just replace. And the nursing role, there's a whole other hour session we can talk about why it is that people don't want to become nurses anymore.
Or have left.
Yeah.
Who are there. It's the retention issue too.
Yeah.
I agree with everything that's been said. I have, other thoughts, which relates to what Dr. Contreras was saying earlier about, kind of follow the money. Yep. And see, why do we have shortages, and where, and in what areas, what specialties, like who controls decision making around quotas. And other countries have societally accepted a different physician or clinician to patient ratio. And that's something that, you can look at statistics globally to understand where the US falls in particular. But I'll just say, coming out of, and I'm not a clinician, but I see this on my team and with our customers, some of whom are healthcare systems. So work with a hospital. The majority of their employees are female. Many of them have come out of COVID, are wildly burnt out, are have not been, adequately cared for or compensated. And we will be there talking about how do you support your employees in midlife women's health in the 40s and 50s and 60s. And I will tell you, time after time, I'm told we're really focusing on fertility and maternal health. Like, we're just not having that conversation. And I just think that's really a travesty, because these are some of the best and most important years of a person's career. And we need to keep them in the healthcare system for our sake. And so, that's a bit of a different lens on the question, but we see it show up in terms of the women we take care of, who themselves may be healthcare professionals.
That's right.
Definitely. And there was a question actually about fertility, about how there are definitely increasing fertility challenges, geriatric pregnancies. What are things that we may be able to do to support women through all of these changes and experiences? Any thoughts on that?
Is that really something that you guys say in the US, geriatric pregnancy?
No, I've never heard of that.
I thought it was only on TV that I'd seen that.
No, it's not what we use on the medical front. My God.
I mean, I definitely have heard of that. And
people get that diagnosis.
Yeah, I don't know if it's a real diagnosis, but in the meantime, the point being is that there are more women who are older who are getting pregnant today than ever before. And what's interesting about that is they face unique challenges that other younger women might not face, right? So we see more complications related to medical issues in women who are over the age of 35. Personally, I can't stand the idea that advanced maternal age is at age 35. To me, you're like super young. Like, that's not advanced maternal age, right? But it's recognizing that the needs of and this is where I think healthcare really falls down for women. I don't care if it's contraception. I don't care if it's maternity. I don't care if it's menopause, perimenopause. When you are 25, you have one set of needs. When you're 35, you have a different set of needs. Both of you could be pregnant, but you have different medical issues. You have different needs. You could be pregnant at 45 and your issues and needs are very different than you were 25. I think the same thing happens in the perimenopausal space, right? You can be perimenopause at 35, at 45 and 55, and they're all different. And I think we lump it all into one box as opposed to taking the me care approach, personalizing it for the individual. And I have to say, if we want to call it geriatrics, a 35-year-old who has all kinds of chronic medical problems may be a very different player than a 42-year-old who's super healthy and has nothing wrong with her. And it's really about taking the approach that we are all different, and that what we need from the medical system is that we get care based on what we value and what we need as an individual, as opposed to just lumping us all in together. So I don't have a good answer as to what the question is. I just know that what it means to me is that we need to make sure that we're taking care of the person and their needs and not getting too caught up in their labels and their age, because that may not be reflective of the needs that they have in healthcare.
Couldn't agree more. And I just reading the question, I think there was a specific question around the threats to IVF going forward, which I'm actually curious to hear your take on, Dr. Contreras.
Oh, I think, IVF is a really interesting thing. I don't want to get too deep into this, but it's this concept of people are trying to bring up the idea of personhood, right? And is a fetus a person? Is an embryo a person? I can't answer any of those questions. To me, they're not. They're just cells. But But I think that's what this comes down to. So if we end up on the side of personhood, which will complicate everything on so many levels, then it starts to have the idea that IVF will be challenged. What do you do with those frozen embryos? What do we do with the embryos that are not going to be viable, and we know that they're not viable? Right? There's a lot to IVF, and it's not just as simple as people think. It is a pretty complicated process that the embryologists go through, and so I think it brings up a lot of questions that are now being seen in a whole different light. So I don't have a good answer to it. I think the challenges to IVF are going to be very large going in states that are interested in developing personhood as a concept.
Thank you for that. And I think the big thing is really seeing that it's not one size fits all, right? Every person, every body is unique with individual needs, and really seeking out a team to support you wherever you're at, I think is really important. So in closing, we've heard a lot about the current state, how things are going, possible innovations, and it's always inspiring to hear about successful examples, right? To help us really see potential opportunity. And I would love to hear from each panelist maybe one or two successful examples of advocacy and action that have led to improved healthcare outcomes for women. And hopefully we can share that with our audience, whether they're individuals, organizations, so that they can really mobilize to create a more inclusive and comprehensive healthcare system for women and all.
I can think of one example off the top of my head, and that was, and it's just this thing about how you need to grab the opportunity when you can. So these policy windows don't come very often, but where they do come, that's when we need to recognize them, and we need to stand up and do it, just do it. And I mean, the example that I have to share is how in the pandemic, the UK put in some temporary measures to make telemedicine available for early abortions before 10 weeks. And that became this kind of temporary measure during COVID, and it got voted in the post-pandemic era. It was tried to be taken away again, but eventually it was voted in favor. So now, with data and with collaboration between policymakers and legislators, as well as the medical community that have been collecting this data whilst they were doing it, so they could have some robust data affirming the safety of the measures, and thus now we have it and it's available, and it just takes away the barriers. It takes away the barriers of access to care, and it enables us to provide abortion in actually a very person-centered way, where a woman doesn't have to travel far to go to the clinic. She can have a telephone consultation with a nurse, and the tablets can be posted to her. And it's the same thing that's happening in the US, where telemedicine abortions are available. That I understand you're actually able to partially counteract this horrendous outcome post-obs. So that's just one example. I think when you see the situation, you have to just make the most of it and just grab that policy window when you can.
I'll maybe piggyback off of that, because I think the term doula came up a lot, and in the spirit of allied health professionals and in community health. And I think that there is such a role to be played there. And if I squint, it looks positive with certain states in the US starting to reimburse for those services. And maybe it starts with birth doulas, but my hope is that it continues to grow and include abortion doulas and menopause doulas and a whole cadre of people whose role it is to support and educate and promote preventative care. I think we're kind of all very much on the same page there, but unless it gets paid for, it doesn't happen. And so we just need to see more of that. And but I really think that is a positive development that we see, and there's lots more we can do on that front.
So I could go on forever about some of these great things I've seen go on, right? The way some of these telehealth companies are trying to address the things that people value in their time and how they get things done, I think is really impressive. I also think something that I never thought would happen in my career is what's called asynchronous care. We see that with medication abortion. You fill out a form and people trust you to fill out the form correctly and that it's okay. And this concept of trust is a whole new concept. So I know it sounds really funny that innovation would be the concept of trust, but that you trust a patient, that they know themselves, they will answer honestly, and that you can take care of them in a whole new way. And I think that's just truly exciting. So much of medical has been not about trusting patients. They don't know, what do they know? It's like, and now we're seeing a whole world where we trust people to write it down and tell us what their needs are. And then we take care of them without having to put them through this whole other process. And so I think that is truly exciting, the concept of bringing trust to healthcare and respecting that women know some of their needs and their bodies. And so we need more of that. And I think it's truly exciting. And I think it's, in my entire career, I've never seen that. It's breaking away from that paternalistic view that only the doctor knows, right? And so to me, it's super exciting. We need more of it. And we just need to keep demanding more of it.
Absolutely. And on that uplifting note, thank you so much, everybody, all our experts for joining, our audience for participating, and really enjoyed this conversation. And I hope you all enjoy the rest of the summit and be well. Thank you so much.
Thank you.